Well, good afternoon, ladies and gentlemen. I too would like to thank the program committee for including me on the program. And there's an old saying about speakers. You should stand up to be seen, you should speak up to be heard, and you should sit down to be appreciated. So I'm going to make this relatively brief. I have chosen this topic because it reflects some work that we did at a startup level 1 trauma center in the Middle East. And I seek to address and answer 3 questions for you. The first is, following blunt trauma, what role do rib fracture patterns play in predicting concurrent solid organ injury, that is, solid organ injury in the abdomen? And secondly, do coexisting rib and pelvic fractures change these dynamics? And if so, in what way? And lastly, is clinical chest assessment more predictable of underlying serious chest injury than plain chest x-rays? And although these sound like fairly simple questions, they have significant practical use in those of us who take care of injured patients, including our field providers or paramedics. I'd like to recognize at the beginning of this presentation the work of 2 colleagues in Qatar, Dr. Ammar Al-Hassani and Dr. Ibrahim Afifi, who contributed measurably to this work and who are responsible for doing a lot of the hard work for me and for the project. This work came from Qatar in the Middle East, and if you're not too familiar with the area, you could see Qatar sits right here. It sticks like a thumb off the east coast of Saudi Arabia into the Persian Gulf. It has a population of about 1.8 million people, of which only 300,000 are native Qataris. This means that 1.5 million of the people that live in this country are from elsewhere. And as we will see with some of the demographics, 95% of the trauma patients that we see in this country are male, and it reflects the large number of individuals, laborers from the Asian subcontinent that come to Qatar and do construction and build roads and skyscrapers. This work was done at the Hamad General Hospital. The Hamad General Hospital, I think, is fairly remarkable because it has one of the busiest emergency rooms in the world. This emergency department has 1,200 visits a day, or 450,000 visits in a year. And we'll come back to the significance of that when we talk about the 3rd research question. Well, the first research question relates to rib fractures and patterns of rib fractures and the occurrence of solid organ injuries. We already know that rib fractures are an indicator of blunt torso trauma. This was a combined retrospective and prospective study involving 310 patients who sustained blunt trauma. 296, or 95%, were men. All had clinical assessment using ATLS criteria. They all had a plain supine chest film in the emergency resuscitation room, and then they had CTs of the chest and abdomen. These were the mechanisms of injury. The mechanism of injury in this particular group was largely motor vehicle followed by falls, and these are not falls on the sidewalk. These are falls out of high buildings. So these are falls from heights from which they can sustain significant injuries. And then there were direct injuries to the chest from assaults, for example, and then there were others like pedestrian ATV crashes and this sort. The mean age was 35 years. The mean ISS, 13. And the median chest abbreviated injury scale was 2. And there were solid organ injuries in 90 of these patients, and AIS 1 to 2 in 57, and an AIS 3 to 4 in 33. And this is the group that we're most interested in. and the total number of organs injured was 116. We arbitrarily divided the patterns of rib fractures into upper, middle, and lower zone. Upper zone, the first 4 rib fractures. The middle zone, ribs 5 through 8, and a lower zone, ribs 9 through 12. When we looked at the patients that had rib fractures strictly isolated to these 3 zones, we found that there was a significant relationship between the number of injuries, solid organ injuries, and the zones where the rib fractures occurred. Specifically, reached statistical significance in the lower zone injuries. If we looked at the larger group of patients where there was an overlap among zones, but where the zones were included as a primary zone, we saw that this, if you looked over at this column here, you saw that again there was an increasing likelihood of solid organ injuries based on the zones where the rib fractures occurred. So, and there was very little difference in terms of the actual organs injured in this group of patients. We then looked at the absolute numbers of rib fractures, and we found there was no correlation whatsoever with the actual number of rib fractures and the prediction of solid organ injuries. In the first line, you see 5 or fewer rib fractures, 6 or more, and there was virtually identical numbers of solid organ injuries. So there was no correlation with the absolute number of rib fractures. We then looked at the occurrence of pulmonary contusions, and we found that there was a distinct relationship between the number of rib fractures and the occurrence of pulmonary contusion, almost a linear relationship. So the number of rib fractures, the absolute number, has a good relationship with the occurrence of pulmonary contusions, but no relation to the solid organ injury rate. So we concluded on the basis of this study that the level of rib fractures was more important than the number of rib fractures in predicting solid organ injuries, and that lower rib fractures were a significant predictor of solid organ injuries in this study, greater than 50%. That the number of rib fractures was more important than the level in predicting pulmonary contusions, and that those patients that had greater than 6 rib fractures were linked to pulmonary contusions in 89% of patients in the study. And we found that the large number of rib fractures, the number of contusions was very high. We then wanted to see whether or not this relationship held or was somehow altered by the patients that had rib fractures and had pelvic fractures at the same time. And so what was the effect on the appearance or the occurrence of solid organ injuries when rib fractures and pelvic fractures occurred together? And does it modify the predictability that we established with the rib fractures alone? This was a prospective study of all patients admitted with multiple rib fractures, either isolated or in a polytrauma setting. There were 460 patients, 436 were men, again, a 95% association with the patient population. Mean age was 37. We defined the rib fracture patterns as that which we did in the first study. And then we identified the subgroup of patients that had pelvic fractures, and we used patients that had pelvic fractures alone with no rib fractures as a control group. So we had 131 patients, and as you see here, there were 74 spleen injuries, 60 liver injuries, and 40 kidney injuries in this 131 patients. If you look over here, in the control group, the appearance of solid organ injury with pelvic fractures is 15%. And with rib fractures only, and this includes all levels, it's about 26%. If you combine rib fractures and pelvic fractures, it jumps up to 41%. But if you look at pelvic fractures and lower rib fractures alone, the relationship showed that solid organ injuries occurred in 61% of patients, highly significant association. So if you look at the comparison then between pelvic fractures and rib fractures alone, you see in the blue the rib fractures alone, and the red with rib fractures and pelvic fractures. And you can see what it is, it exaggerates the original findings in the rib fracture study. So we concluded, based on this data, that the presence of pelvic fractures and lower rib fractures is highly predictive of solid organ injury compared to pelvic fractures alone, and that pelvic fractures increase the likelihood of solid organ injury when associated with rib fractures regardless of the level, and that the presence of lower rib fractures and pelvic fractures is often apparent on clinical exam and should alert the clinician that the patient is at high risk for solid organ injuries. And I'd like to amplify that on that a little bit, because you can make this diagnosis in the field and in the emergency department without an x-ray. You can get a sense that there are lower rib fractures when you examine the patient, or that the pelvis is tender to motion. So you can gain an appreciation for the fact, without any x-rays or studies, that this patient is at high risk to having a solid organ injury. Now, to get to the last research question, we asked this question related to the statistics I showed you earlier, the fact that we've got an emergency department that sees 1,200 patients a day. What I didn't tell you is we had 2 CT scanners, and it not only served these 1,200 patients that came in through the door every day, but it also served the entire 600-bed hospital, which means one thing: you've got to prioritize the patients that you're going to send to the CT scanner. And even though we had a priority for trauma patients over all other patients in the hospital for the CT scanner, we needed to be fairly even-handed in how we demanded the use of the CT scanners. So we felt that there was some justification to try to determine which patients needed to go first to the CT scanner for a thoracic CT. So the aim of the study was to answer these questions. Does clinical assessment correlate with thoracic CT-based injury severity determinations? In other words, we used the thoracic CT to determine the injury severity, the chest injury severity in the patient. And is this clinical assessment more or less sensitive than a plain chest X-ray in patients in defining this severe chest injury? And what's the role of thoracic CT in the early management of the trauma patient? So we had 400 consecutive patients with blunt chest trauma in this study. All had clinical assessment according to ATLS guidelines. They all had plain supine chest X-rays in the resuscitation unit, and they all had thoracic CT scans. And injury severity was defined as serious by an AIS of 3 or greater. And as an example of what that is by definition, it's major lung contusion or laceration, hemothorax greater than 1 liter, greater than 50% pneumothorax, a hemo or pneumomediastinum, cardiac tamponade, rib fractures with flail chest, an open thoracic wound involving 15% of the chest wall, or sternal fractures and comminuted scapular fractures. These would fall into what would be defined as, quote, serious chest injuries. Again, the causes were mostly related to motor vehicle collisions and falls. This purple line here, which you see we defined it as thud. These were patients that were struck by falling objects, usually off tall buildings to the workers below. We have a significant number of those patients in a series that was reported elsewhere. So the final study group was 138 patients that were defined by CT as having AIS 3 or greater, made up 34% of the original study group. And of 10 clinical criteria that were assessed, 4 were found to be useful in determining serious chest injury. And we found that any two of these 4 criteria were highly reliable, greater than 95% accuracy, in determining an AIS 3 or greater injury to the chest. And these 4 criteria, and they're worth remembering, that is tachypnea greater than 24 breaths per minute, O2 saturations less than 95% on room air, chest wall tenderness, and decreased air entry on auscultation. These were the 4 criteria that we found to be highly significant in terms of diagnosing severe chest injury. And when we looked at these, and you can see how statistically significant they are, if you had an impaired saturation and a respiratory rate of greater than 24, it's highly significant in determining the AIS-3 chest injury. And you can just follow this chart down: decreased air entry and tachypnea, or decreased air entry and SiSO2 less than 95, all significant predictors. Tenderness was less predictive, but when combined with any of these was highly reliable in predicting this injury. And if we looked at the patients that had AIS 1 or 2 injuries, 73% of these patients had chest wall tenderness, but none of them had any of the other criteria that we used, that is impaired saturation, elevated rate of respirations, or decreased breath sounds. So then we took this information and we looked at, we compared this with the results that we made on chest x-ray alone. And here you see we had 130 of the 138 patients that had rib fractures or chest wall tenderness. Chest x-ray picked up fractures in 96 out of these for a 74% likelihood of predicting it. Pneumothorax, 65%, hemothorax, 16%. Chest x-ray picked up no sternal fractures, that's no surprise. Scapular fractures, just 2 out of 40. So chest x-ray is not very helpful for scapular fractures. And soft tissue injuries largely related to pulmonary contusions, and that was 35% accurate. So there are some significant limitations of plain chest x-rays in the establishment of severe chest injury, largely based on many times the films are inadequate that are obtained by portable technique. There may be some delay in the evolution of pulmonary injury, so it's not seen on the chest x-ray, but is picked up in the earlier signs of the CT. Maintaining spine protection, especially if the patient remains on a blackboard when the x-rays are taken, causes problems. Supine position, we know, is a problem in terms of interpreting the chest x-ray. And then, of course, the quality of portable films, as already mentioned. So in conclusion, to this third research question, we can't overstate the value of clinical assessment in determining patients that have significant chest injury, and that it can define the patients who need chest CT and the patients for whom a chest x-ray may suffice as the initial screening tool, that is the AIS 1 or 2 patients. And that the chest x-ray is a poor method for determining injury severity in most patients. And that clinical assessment in combination with chest CT is highly accurate in defining AIS-3 thoracic injuries. In closing, I'd like to recognize the trauma service at the Hamad General Hospital in Qatar. They're a group of very enthusiastic trauma surgeons who worked there and helped build this program. And I also like to thank the Pan American Trauma Society for their role in building bridges between North and Latin America. Thank you very much.